So our workup of thalassemia would start with the full blood count showing the microcytic anemia associated with reticulocytosis, and then blood film. This is characteristic blood film that show target cells, of thalassemia or chronic hemolysis. Then also this a characteristic blood film that show here we have minimal anisocytosis and poikilocytosis, which means that all cells more or less are comparable in sizes, and so we have a low level of RDW or rate of cell of distribution of red cell widths. We're having RDW less than 13 is characteristic and differentiates thalassemia from other causes of microcytic anemias. Other lab work would include the HPLC or hemoglobin electrophoresis to find the low level of hemoglobin A and the compensatory high levels of hemoglobin F and normal levels of hemoglobin A2. Finally, gene testing would confirm the beta thalassemia as the cause of this chronic hemolytic state. As a management, these patients are chronic patients, should undergo a blood transfusion regimen to keep hemoglobin level at about 10 gram per dl. The level change from one center to another. So keeping the hemoglobin level at appropriate level is the target to maintain normal growth and quality of life of those patients. Frequency of blood transfusion depends on the severity and depends of the incidence of anemia. So as we have mentioned, our aim is the normal growth and normal quality of life of those patients. But besides the blood transfusion program, another program of iron chelation therapy should be arranged for, otherwise hemosidrosis would develop. When to initiate the iron chelation? Usually ferritin levels are followed up during transfusion until reaching a level of 1000 maybe, where iron chelation would start. We have two types of iron chelation, either oral chelators, which recently become widely used, replacing the desferrioxamine, or maybe both used parallel to each other. Desferrioxamine, which is taken as subcutaneous infusion like this, using infusion pump that is used overnight, about 12 hours a day, usually used 5 to 6 nights per week. So this patient with thalassemia using this ferrioxamine, using an infusion pump subcutaneously, about 5 to 6 nights per week and 12 hours per day, and where this ferrioxamine help to bind iron and excrete it in urine. This was in the past the main line for iron chelation, but recently, importantly, we have the oral agent, including the deferriprone and desferrizox. These are very important agents to remember and know, and they are widely used now, to reduce the suffering of those patients. They are safe and effective, having minor side effects, maybe the most common of which is arthralgia. While bone marrow transplantation, which is the only definitive therapy for thalassemia that is kept for patients who have an HLA matched sibling. Okay, this would be discussed with the patient and the family to face the risks and the benefits if the transplantation would be cost effective or not, as it carry risks of immune suppression and high morbidity and mortality. But in some centers it is used as a definitive curative therapy for the disease. We have a condition called beta thalassemia trait. It is a heterozygous form of thalassemia, which means that we have just one mutant gene. Okay, so this is the carrier form of beta thalassemia. Usually, as we have mentioned, this individual have no manifestations of anemia, may have mild anemia, maybe. It would be, this individual would be discovered when doing an FBC full blood count, which shows that he has normal level of hemoglobin, maybe 12 or something like that, while he have microcytosis. Okay, so unexplained microcytosis in the face of no anemia, okay, would raise the suspicion of a beta thalassemia trait. Usually, hemoglobin electrophoresis of this individual would show a high level of hemoglobin A2. Hemoglobin A2 more than 3.5% is characteristic for the beta thalassemia trait, so it would enter in a differential diagnosis of iron deficiency anemia due to the microcytosis, but ferritin levels would be normal in this case. So this individual has no manifestations clinically, but his blood count shows microcytosis in the presence of no anemia or mild anemia with normal ferritin level, and hemoglobin electrophoresis show normal levels of hemoglobin A, but higher level of hemoglobin A2. Of course, he need no further workup or therapy. Alpha thalassemia is associated with reduction in the rate of synthesis of alpha chains. Also, it is an autosomal recessive disorder. Here, this is a normal hemoglobin that has four alpha chains. Okay, we have, as we have mentioned in the hemoglobin molecules, two alpha chain and two beta chain. For these two alpha chains, we have 4 genes. When we have normal 4 genes, this is the normal individual and the normal hemoglobin. But having one mutant gene, this would be associated with a carrier of alpha thalassemia who is asymptomatic and has no abnormality. But having 2 mutant genes of alpha thalassemia result in also alpha thalassemia minor, which usually asymptomatic or present with mild microcytic anemia. So alpha thalassemia is a differential diagnosis for mild microcytosis associated with anemia after exclusion of beta thalassemia and iron deficiency anemia. So having 2 mutant genes would result in alpha thalassemia minor. Having 3 minor genes, this is much, okay? 3 mutant genes of alpha thalassemia give us the HPH disease or hemoglobin H disease, which is symptomatic, present with hemolytic anemia that is microcytic anemia associated with splenomegaly. This is a differential diagnosis for beta thalassemia. He may be alpha thalassemia. This would be confirmed only by genetic testing. Having 4 mutant genes of the alpha chain would be incompatible with life due to complete absence of the alpha chains. Complete absence of the alpha chains give us the hemoglobin parts, which have 4 gamma chains, okay, that is result in hydrops fetalis and intrauterine death or death shortly after birth. Okay, this is incompatible with life to have no alpha chains at all. Okay, then the second disorder of chronic hemolysis due to hemoglobinopathy is sickle cell disease. In sickle cell disease, we have qualitative abnormality in hemoglobin molecule, where we have abnormal hemoglobin rather than quantitative reduction in synthesis of the globin chains. Here, the abnormal hemoglobin is called the sickled hemoglobin, which under certain circumstances of low oxygen tension undergo sickling and the change of the characteristic normal disc shape RBCs into a sickled RBCs like that, which are vulnerable to sticking together like that, resulting in a thrombus formation and occlusion of different blood vessels, giving us the manifestations of sickle cell anemia. Okay, due to destruction of these abnormal red cells in the spleen, and also due to vascular occlusion. We have different forms of sickle. Okay, if we have both, also sickle is autosomal recessive condition like thalassemia, requiring two mutant genes to be present to express the disease, having two mutant genes resulting in the SS form, or the sickle cell disease showing the manifestations of sickle cell anemia, while having just one mutant gene giving us the carrier state or the sickle cell trait, which usually asymptomatic or having mild, very mild manifestations. This is called the sickle cell trait. We have other abnormal forms of hemoglobin that are associated with qualitative disorders like hemoglobin C, giving us the hemoglobin C disease. We have hemoglobin C trait and so on. Okay, sometimes we have a mix between hemoglobin S and hemoglobin C, giving us hemoglobin SC or sickle cell hemoglobin C disease that also would be associated with chronic hemolysis. Sometimes we have the mutant gene of thalassemia associated with the mutant gene of sickle cell, giving us the sickle cell thalassemia. Also, it would be associated with chronic hemolysis, mainly manifestation of sickle cell anemia, but associated with splenomegaly. This is characteristic. Usually, sickle cell anemia not associated with the splenomegaly, or associated with splenomegaly in the start due to the hemolysis and the compensatory extramedullary hematopoiesis, but with time, with recurrent micro thrombosis and microinfarctions of the spleen would result in hyposplenism rather than, and splenic atrophy rather than splenomegaly. So finding splenomegaly with a sickle cell disease would suggest the diagnosis of sickle cell thalassemia. This can be a scenario you face in the exam. Okay, so this is different forms of abnormal hemoglobin. In the electrophoresis, the normal, we have, okay, mainly more 97% of hemoglobin is hemoglobin A, okay, alpha 2, beta 2, while a small percentage of hemoglobin F, alpha 2, gamma 2, and below 3.5% of hemoglobin is hemoglobin A2. This is the normal pattern. In case of hemoglobin S, which is autosomal recessive, and we have two mutant genes, so we have no hemoglobin A at all. We have the small percentage of hemoglobin F, hemoglobin A2, and the main bulk of hemoglobin is hemoglobin S. Okay, hemoglobin S can start manifesting after the age of 6. Okay, when the hemoglobin F is replaced by hemoglobin S, okay, or can present in the neonatal period with neonatal hemolysis. All this according to the amount of hemoglobin S in relation to hemoglobin F. Increasing hemoglobin F percentage is associated with milder manifestations.